Hello, everyone who just joined in. We're gonna wait another 30 second or a minute to see everybody show up, and then I'm gonna do the intro, and then Madeline will start the presentation. Another 30 second. Well, it's always amazing to see how many people join in. Okay, good evening, everyone. And first of all, thank you for registering and thank you for attending tonight. I'm happy to see so many of you and to come here tonight to hear about Beyond the Basic, a modern framework for high quality bubble studies. Tonight we'll hear Madeline Jankowski, a sonographer at Northwestern University and also our clinical educator, talk about bubble study challenges and new tools and technique that can help to address challenges and help you make your lab more efficient and the most important, get closer to the holiday. Some people will be on vacation. We're gonna get more and more backlog, and normally bubble study are not necessarily the priority, so they're gonna be either shovel forward in January. But anyway, now you have a tool that can help us, and Maddie is going to talk about it. So don't forget, following the presentation, we're going to answer all the questions. If you go down on your screen, you're going to see chat. Chat is going to be for if you have any issues, like don't hear anything or etc. But all the question, please ask it at Q&A because we're going to answer this at answer those questions at the end of the presentation. Also, to get CME credit, you need to fill the survey. If you stay online a little bit after the presentation, it's going to pop up and you're going to be able to fill in tonight, which I encourage you to do if you want your CME credit, because your humble servant here will have to do it, and it's extremely long, and we don't have that many days before the holiday. So I would like to give everybody their certificate by the end of the year. It will be a challenge. So if I get all the survey tonight or tomorrow, that will be very helpful. On this, I will let Maddie start.
Great. Thank you so much, Martin. And let me share my screen here so you guys can see my presentation. All right. So thank you again for being a part of this webinar tonight and taking your Tuesday evening with us. Again, my name is Maddie Jankowski. I am a cardiac sonographer and the clinical specialist for Agitated Solutions. I work and practice in Chicago in the United States, and I'm really excited to be presenting this Beyond the Basics talk, a modern framework for high quality bubble studies. So our goals tonight will be to provide an understanding and really go through the history of agitated saline contrast studies. But really what we want to focus on is how variability affects these agitated saline studies. And I have some cases to show you tonight that demonstrate those effects. We also want to look at some effective maneuver techniques. And then I'll end with an agitated saline study toolbox that you can go home to your lab with and hopefully help with your technical quality. So let's go ahead and start with just what is an agitated saline study. So when we're talking about agitated saline, a lot of people know it as the bubble study. And I'm sure you have all practiced and performed these before. The primary use is to identify a right to left shunt. And many of those shunts may be a PFO. And we know those PFOs can be the cause of an embolic stroke. Bubble studies can also be used to enhance our TR jets when we're looking for those really accurate RVSPs. We sometimes perform them in HHT studies or times when we're looking for a pulmonary AVM. Also, we can sometimes use bubble studies to help with catheter placement. So whether that's just observing where that vessel is and where the best placement would be. Now, these bubble studies are important because we know that about an estimated 25%, a quarter to about a third of the population has a PFO. And we know that nearly 30% of strokes are due to emboli. So if we can really identify these folks that have the PFO and are at risk for these strokes, that would be really important for these patients. We also know that 23% of these patients who have had a stroke suffer another one. So again, if we are able to diagnose this PFO or some kind of shunting and get them to treatment, they might not suffer that second stroke. As we know, bubble studies have been around for a pretty long time, longer than I've been alive. So the first bubble studies were described actually in 1969 there was some literature that was first put out. We then go on to 1975, where we looked at bubble studies a little more to look at right to left shunting. That 3-beat rule that says, within 3 beats, if the bubbles appear, it's a PFO. That rule came about in 1976. So, almost 50 years ago. The first ASC published guidelines about bubble studies were not until 2001. 2015 is when some more recommendations came out. But it's 2025, and from 1969, bubble studies have really largely remained unchanged. And so I really want to talk about some of the features of these that we still kind of have issues with in our practice. So when it comes to what we're looking at, the outcomes and how to look at the variability and subjectivity of these bubble studies, I think there's 3 really distinct pieces that can have variation. One, and I think almost most importantly for the sonographers here, the bubble study quality itself. So contrast quality, if you performed a maneuver, how was that? And obviously the image quality is important. In terms of bubble study interpretation, there can be variation in, are we still counting bubbles? There's also some pretty unclear closure guidelines that for all of the trials didn't quite line up. So there can be some subjectivity and variability with the interpretation. But then, down the pipeline, that leads to a variability in the accuracy of diagnosis. So we know that, if a poor bubble study is performed, additional diagnostic procedures may be required, unnecessary procedures, and of course, we missed that diagnosis on the first go. So what I'd like to do in this talk is really pick apart these 3 types of variation and look at cases that demonstrate that. So with bubble study quality kind of being the biggest one, I'd like to save that for last. So we're going to work backwards here. And I'd like to start with this accuracy of diagnosis. So case 1 is a 42-year-old male who presents to the emergency department with a headache and left-sided weakness. As the stroke workup was ordered, this TTE with agitated saline was ordered. And I'll play for you the bubble study clip. So here we're seeing that nice apical 4 chamber, and here the bubbles come in. And as we're watching this whole clip and the bubbles come in and, obviously it looks like a negative study. We're not seeing any of those bubbles over on the left-hand side of the screen. But what I'm really looking at in this study is the fact that when those bubbles appear right now, they really aren't opacifying that whole right heart. And it's really a challenge to think, were there enough bubbles to even cross? So because this patient was so young and they were in the ED, they went ahead and ordered a transesophageal echo to rule out that PFO. They saw that multiple TIAs were diagnosed on a CT scan, and so this further testing wanted to be done to make sure this younger patient didn't have another stroke. But we see on this TTE image with this really great influx of bubbles that we see that positive study. So even though it's a very small shunt, because of that nice opacification of the bubbles, we were able to finally see that. And I think, to bring this back to sonographers, I'm sure that there's been plenty of times that you've gone to the bedside and, maybe explained a bubble study to the nurse or who's ever doing the injecting, and those bubbles just don't look right on your screen. And so I think that last image really showed, when we assess these bubbles coming in, how do we know that it's been a good bubble study? So that's one of the things I wanted to bring up in this case was that with the TEE, we now see that this really nice opacification was done, and that's how it should be on that transthoracic image as well. So when we're looking at accuracy of diagnosis, the couple things that kind of stood out to me in this case were that additional procedures were needed to be performed in this patient. So not only did he get a TTE, but he had to swallow a probe and get additional images. And so we were able to finally get that diagnosis, but that transthoracic echo did not show that result. And again, that misdiagnosis, say that he wasn't able to get that TEE, he may have gone on to then, have another stroke, but thankfully, because we have the diagnosis now, he was able to be treated. And so really, I like that case because the accuracy of these diagnoses are really important, and making sure that the quality of our bubble study will help lead to that accurate diagnosis. So just a little bit of background behind, this patient in particular was a younger patient that had a stroke. And when we look at the cause of strokes in young adults, there's a really variety of things that they can get strokes from, but PFO is a big player in this field when we're looking at the cause. And some of the features that can be on the echo that can maybe tip you off a little more to this PFO, or say, is it high risk, is the shunt size. So we saw that patient that just had a couple bubbles through, I'd call that a small shunt. But if we see a lot of bubbles, that could put them at a high risk. Atrial septal aneurysm also puts these patients at a higher risk for a stroke and having a high risk PFO. So seeing that more mobile septum should really clue you to thinking, I need to interrogate that intraatrial septum a little bit more. We also provide a rope score and a recent VTE on these patients. I think the shunt size and the atrial septal aneurysm are the things that you will be most familiar with on the echo. So some features of these high-risk PFOs that just to be aware of in these patients, especially younger patients that get these strokes. The number of bubbles that's used to quantify the PFO. So we look for the size of the shunt to say, is it a small, medium, or large PFO? How many bubbles are coming through? And that may guide the physicians and the care team about whether to treat this PFO or not. Also, again, when you have that aneurysmal septum, that really wavy, floppy septum that's really mobile, that can also be a feature of a high-risk PFO. So just another thing to be aware of while you're doing your apical scanning. If they have a eustachian valve that's directing the venous flow directly at that PFO, so this is an image C over at the bottom left of this screen. So sometimes that eustachian valve is kind of cornered in that atria just so that the flow coming out of that goes against the PFO. And now if there are any little thrombi in there, that could really, push them through that PFO opening. And then finally, Chiari network, if you have a Chiari network, that can also help, or that can facilitate the development of thrombi. So just another feature to look out for as you're evaluating these patients, especially the young ones. This is just an example of a high-risk PFO on a TEE. So seeing this color flow here that they identified, but then in this bubble study, we really see this pretty highly mobile septum. And then within, immediately when they injected those bubbles, we start to see them over in the left atrium at the top of the screen. So let's move on to the next layer of variability here. I want to talk about the bubble study interpretation. So how are we, if it's a physician or if you're a sonographer doing preliminary reporting, how are we interpreting these bubble studies to the accurate diagnosis? So are you counting the bubble, counting the number of cycles to say, yes, it's a PFO, or yeah, that was late bubbles for a PAVM? Are you actually counting the bubbles in your lab to say that's a small shunt, that's a large shunt? And again, some of these closure guidelines are a little unclear. So some of the variability in treatment can come from that. So let's go through, and this is a just fascinating case that I came across of a 39-year-old female that presented to established care with a cardiologist. She's got a personal history of congenital heart disease, and she was 39 back in 2009 when we started taking care of her. Her past medical history includes a double orifice mitral valve and a possible ASD PFO. Other past medical history includes stage 2A invasive ductal breast cancer in 2009, and she did have a PE, a pulmonary embolism in 2007, but both of those things have been subsequently treated. She presents healthy and well, no current symptoms or events in 2009. So I want to play this clip for you from a TEE that was done in 2009. This is the bubble study from that. So injecting the bubbles, and then we see right away, we see those bubbles up in the left atrium within probably, a half a second. So I think, for all intents and purposes, this was read out as within the 3-beat rule, this is a PFO. And because of the number of bubbles over in the left atrium, this was considered a pretty large one. So fast forward, that was 2009. She was healthy and well. 2023, she had been followed up for some care, but then also she was lost to care for a little bit, but came back and presented to the emergency department. So now she's in her early 50s. With 2 weeks of persistent dizziness and an episode of right arm weakness and right-sided facial tingling. A TTE was ordered to reinterrogate what was thought to be an ASD. So at that time, when they saw it before, they didn't close it, they didn't do anything. And so this was the echo, the transthoracic echo performed in 2023. Now let me play these bubbles for you, and I'll let this clip play. All right. So here is our bubble study. And then all of a sudden we see bubbles over on that left-hand side, but to be very honest, I really didn't see many bubbles come in on the right side. So this is a really interesting case, especially from a TTE perspective. The bubble study quality was poor, so we really didn't see the bubbles too well. We did see them over on the left side. But maybe, was that due to just the image quality of this patient? This patient has a history of breast cancer and concomitantly had breast implants put in, so this imaging was a little tricky. But still, we weren't able to quite visualize that right side really well. We didn't see a big influx of bubbles, so we can't quite tell when this was positive. So, if I just went from the beginning of this clip, I would say this is a late study, but we saw in that transesophageal echo that she had this big old PFO. So that I'm not quite sure what I'm seeing here, but I know that there's bubbles on the left side. So because of this, reordered to TEE. And if you're wondering, I think they probably do a few more transesophageal echoes here in the United States than they might up in Canada, just being more available. And so this is a very usual practice for them to get a transesophageal echo. But if the transthoracic echo was adequate, this may have not been needed. But let's look at the TEE image. So this bubble study was performed in a biplane view so that we can see the orthogonal views of that septum. And then the physician kind of shifted to try to look over to those pulmonary veins a little bit. But again, so we're seeing within, probably 2 to 3 beats, we're seeing a whole bunch of bubbles over on in that left atrium at the top of the screen. And I think that this is a pretty adequate bubble study. If I'm looking at the transesophageal pictures, I think these bubbles are, opacifying that heart wall, but then also have enough oomph to them so that we can see them in the left atrium. So I want to talk a little bit about, before I get to the conclusion of this case, I want to talk about a little the diagnostic variation across some of these clinical studies. So when we look at the studies that have really looked at PFO closures and when we do them and what kind of are the parameters around them, we can see that there has been quite a few clinical studies done, and they're very similar in defining all of these different parameters, but they're not quite all the same. And so, the top four in this table here are for PFO closure studies. And if you can see, if you look at shunt size, so if we're looking at the grading, all of those are similar. They've got, 1, 2, 3, and 1, 2, 3 down here, small, moderate, and large. But then all of these numbers are slightly different. So I just have found that in some of these studies that some of the literature just doesn't quite add up. And so I feel like we haven't quite gotten the clear answer on this. When we look at those PFO guidelines by the American Society of Echo put out in 2015, there was no mention of shunt size. Cardiac cycles, when they're talking about counting those bubble study beats, they say 3 to 6 cycles, whereas all the rest of these trials said less than 3. The other thing that I think has a little bit of variation is the timing landmarks. So are we starting to count right when we see bubbles, enter the right atrium? Do we see it when the right atrium is fully opacified? Do we wait until the entire right side is opacified? So I think there's some variation in how all of us do these echoes and these bubble studies. And so inherently, there is going to be some variability in the way that we read them. So I'd like to come to the conclusion of this case, which was fascinating to me. So because this woman had come in with multiple, issues that kind of smelled like a stroke, they performed a CT scan of her brain and chest. The brain was to see the impact of the TIAs, and then the chest was to rule out any pulmonary embolism. And while the CT scan was negative for PE, they did find a very large pulmonary AVM on this CT scan. And I put that in this image on the bottom left with the arrow in it. So what this meant was that the lung vessels, the lung pulmonary arteries, were connecting somewhere to the pulmonary veins and allowing that blood flow to come back. And this AVM was, interestingly enough, because it was large, it was able to collect some septic emboli, and it produced the septic emboli that ultimately was led to her TIAs. She was treated with a coil in IR, and so to just prevent those further TIAs and hopefully, prevent any recurrent events. I'm going to play this last bubble study for you, and what I really appreciated about the physician that took this image was I'm not showing the regular bubble study that they did, but then they shifted to look at the pulmonary veins and did a bubble study from there. So here's that. We see this pulmonary vein come over on the left side of the screen. And then now this is after that coil is there. So we see there's still a little bit of shunting, but it is not as vigorous as it was. We're not seeing that huge plethora of that plume of bubbles that we did before. So I just thought this was a fascinating case, one that we're usually taught to count those bubbles, and especially when they're so quick to come into the left atrium. And so this case really had me thinking about trying to visualize those pulmonary veins, whether it is in a transthoracic echo and you're really optimizing the left atrium, or when you're doing your transesophageal echoes to also look for these cases. So again, variability in bubble study interpretation, I think there's a couple things that really come to mind here. So really the visualization of a positive study and subjective interpretation. So remember back to the transthoracic echo that we looked at. That was read out as having because we knew she likely had a PFO, that was read out as having a positive study for interatrial shunting, even though we didn't really see where those bubbles came in, and the timing of it. And so it said it was likely that PFO. Now, again, are we relying on still counting bubbles? I'm not sure if anybody in their labs is still doing this, but are we, it seems like a pretty remedial way to really interpret these shunt sizes and say, yes, that is a big one. And so we need to close this. And so I think, really looking at the features of these PFOs and yes, the size, but really, how the outcomes of the patient can also be included in this evaluation. Again, there's some unclear closure guidance. So I showed you that table of some of the studies that have been performed and the literature that's out there for these PFO closure trials. And now, as much as they give us a little bit of guidance, it doesn't seem like each study is aligned. And so how are we going to come to a conclusion as a field if we don't have the right, literature and things like that? And then finally, I think we've probably all had cases where it's a big question on whether this is a PFO or a PAVM. Are there late bubbles? Is it right at the 3 to 4 beat mark? Or if you cannot visualize it coming from the septum or the pulmonary veins, how does that affect your diagnosis? So the last section I'd like to talk about is the bubble study quality. And I think most of us on this call are sonographers here, so I wanted to spend the most time on this part. But a couple things that I think that can really impact just the variability and the subjectivity of our bubble studies that we perform. I think one is obviously the image quality in general. So is your scan optimally, are you optimizing your scan for a bubble study? Or is it a patient that, is going to be technically challenging no matter what? So we'll talk a little bit about that. Maneuver quality, are you having patients perform a Valsalva or a cough or some kind of maneuver to help elicit some of those labile shunts? And if so, how good are the maneuvers that you're doing? And then finally, the contrast quality, I want to talk about when we see bubble studies that, are really poor, what are we doing about it to, either guide the person that's injecting this or optimizing our image to making sure that we're getting the best picture that we can. So case 3, my last case here, is a 60-year-old female that presents to established care for a prior diagnosis of PFO. So she comes in, we know that she's got a PFO, we just have to prove it. She has a family history of a pulmonary embolism and also family history of stroke. So this is going to be really important to keep following her so that, because of this family history, to ensure she doesn't have an event. But she presents at this visit with no symptoms, no recent events. And so let me play, this was negative at rest. And so we wanted to do it with a cough to see if we could elicit that shunt there. And so we see those nice bubbles come in. And there was the cough right at the very end. But again, this is going to play over, but we can see that there was no shunting seen. We don't see any bubbles on that left side of the screen. Now, a couple things I want to point out in this image here. So one, we see this really nice influx of bubbles. So I think I would start counting those, when the RA was fully opacified. This first couple beats are probably just residual bubbles from that last bubble study. But the other thing that I notice here is that she's got kind of a fixed septum. She's got this intraatrial septum that's a little bit, you know, bent into that right atrium. And so that tells me that her left atrial pressures are maybe a little bit higher than normal, and that any maneuver that I'm going to do is going to have to overcome those higher left atrial pressures. So whatever maneuver she's going to do, I have to have her do it pretty darn good for it to appear. So this image did not show this. I think that, we're not seeing any real movement of that septal shift or anything except for right at the end, but we didn't see any bubbles cross. So because we already knew of this PFO, she didn't have this repeated right away, but then came in for her follow-up echo probably about a year later with another bubble study repeated, saying, let's really try on this one. And I know the physician was in there trying to get her to, really bear down or really cough to make these bubbles stand out. So I'm going to go ahead and play this one for you, but I want you to think about the following questions while you watch this. What's the difference between these two studies, the one that I just showed you now? What impacts the provocative maneuver? How do you know if you've done the maneuver well? And then what challenges do we have to overcome to perform a diagnostic maneuver? So let me play this. I will show you the bubble study. So let's see, bubbles coming in, and then she did a big old cough, and we see those bubbles come over to the right side. And so something I want you to look at in this bubble study, when she does that cough right now, you see that that septum shifts over into the left atrium and really kicks the intraatrial septum over there. That is that shift that we want to see, that I know that we raised those pressures enough and that maneuver was good enough. And obviously we saw it, positive after that pretty hard cough. So again, what impacts this maneuver? So having them do it, long enough, hard enough. We'll talk about Valsalva in a little bit to go through that. But then also how I know we did it well is I saw that septum shift so that I know that we changed those pressures in the atria there. And again, one of the challenges in this study that we had to overcome was the fact that it had that more fixed intraatrial septum and that the left atrial pressures were a little bit higher, and we needed to overcome those. So again, looking at some of the variability, I think this probably has the most impact of variability out of all the things that I mentioned. So when we think about variability in how we do these bubble studies, how we're performing and acquiring them, think about variability in the method of agitation. So how fast or how slow are you pushing those bubbles back and forth? And, are you swishing them, just a little bit, or are you using the full kind of throttle to push it back and forth? Method of injection, are you pushing it fast, slow? Tools used, are you using, the regular stopcock setup? Are you using air in your empty saline syringe? Are you using blood or bacteriostatic saline? So all of these things can introduce variability into our bubble studies. I think then we'll get to talking about maneuvers, the instruction of the maneuver from the sonographer to the patient, obviously the interpretation of that instruction, and then having those patients perform the correct maneuver and well is always a challenge. And then above all, we have overall image quality. So I think, in terms of bubble study variability, there are a lot of things that sonographers have to deal with in terms of getting a similar bubble study every single time. So I want to go through a couple slides on provocative maneuvers and how to, that the case that we looked at had the patient cough, but I think that also a lot of labs are using a Valsalva. And so I want to go through a really good technical way how I instruct my patients. And I like that I put this image together to really look at the timing of this because that's really going to help us do the injection correctly and then also get the results that we'd like correctly. So, I look at this from a 1 to 10 counting. So this is about 10 seconds. So as I start counting, I'm having my patient bear down. And as they're doing that, I'm going to maintain my imaging window. And now I know all of you are saying, Maddie, this is probably the most challenging part is in maintaining that window during the bearing down. And what I'll say is this, is that remember that, as you're adjusting your window, it doesn't necessarily have to be your most beautiful 4-chamber study, because we're really focused on the atria and the interatrial septum and the pulmonary veins. So if your endocardial border definition isn't as great, like if you were going to perform a LVEF, that same image is not as important as getting a good image of the right side and the left atrium for these bubble studies. So as you're maintaining that imaging window, if you have to move a little bit and have it a little bit off axis or slide up a rib space, that may be helpful while you're doing these. Now, as you're having them, they're bearing down, at about 3, 4, 5 beats, if they are bearing down enough, you should start to see their interatrial septum shift into that left atrium. And I'll show you an example of this in a little bit, but this just shows you, it actually physically shows you that that right atrial pressure is increasing, and so that bowing into the left atrium is seen. We inject the saline at about 5 or 6 beats, so it takes a couple beats for it to get in. Once you start to see the RA opacified, that is when you'll have them release. So once those bubbles get in and they're nice and tight to that interatrial septum, you'll go ahead and have the patient release, and then hopefully, if positive, you'll see those bubbles directly after. So how do we assess the quality of a Valsalva? A couple of these slides were taken from Dr. Masika, a really great partner of ours, and just did a very wonderful webinar about Valsalva a couple months ago. And so he really talked to us about how we assess the quality of our bearing down and how on the echo we can really appreciate if they've done a good job. So using that full opacification of the RA is going to guide you on when to have them release. The interatrial septum bowing into the LA can really be a good anatomy clue to help you see if they've done that enough. I will say that won't happen on every patient, but it will happen on most. And then again, the number of beats, making sure they've bared down long enough and you're injecting at that time and having them release at the right time so that the Valsalva is complete. So I thought this was a really great case of a Valsalva. I'm going to just have this. This was a really positive one there, but I'm going to have this play again, but I want to just demonstrate what's happening in each of these frames here. So in 1, we see the opacification. 2, we saw that septum kind of bulge into the left atrium. So if you see an image number 2 at the top right, you're seeing that interatrial septum in that left atrium. In image number 3 is then kind of there, or I guess number 2, whatever, A, B, C, D. Number 2 is, starting to have that bowing. And then here in 3, we actually see the bowing a little more. And then 4, we see that huge influx of this very positive study with Valsalva. Again, when we're looking at the severity of the shunt, that one that we just saw was definitely a large shunt. So it really opacifies the ventricle, almost like contrast does. But then we also sometimes grade them with this, small, moderate, or large. But again, these come from more of counting those bubbles, which is a little bit of a remedial application for that. And some of these pitfalls, as we saw with the last case, some of these, being able to do a Valsalva and having these bubble studies can inherently introduce some false negatives and false positives. So we can see false negatives sometimes when we're unable to properly do that maneuver. So we're not able to raise the right atrial over the left atrial pressure. So again, if that Valsalva or that cough didn't adequately um, uh, increase those pressures, we may have a false negative. Also, the inability to opacify the right atrium. So remember those bubble studies I showed at the beginning where the bubbles were just trickling in, though that can also cause a false positive or false negative. And for false positives, as we saw with the last case, intrapulmonary shunting can easily be a false positive when we're looking for a PFO, especially if they're a little bit earlier bubbles. And sometimes just alternative causes of shunting or incomplete clearance of a different injection. So I want to end with a couple things to use in your diagnostic toolbox that hopefully you can take back to your lab. So one thing we didn't talk about too much, but I wanted to make sure to talk about at the end was, of course, the Orbis microbubble generator. Now, I'm sure that many of you may have been introduced to this or seen this. This is available commercially up in Canada. And please let us know if you have any questions. You can direct them to Martin at the end. But this microbubble generator has been invented to help really streamline the workflow of these bubble studies, but it also really enhances the quality of the actual bubbles and the visualization of these studies. So not only can we save time and hassle, trying to train a nurse at the bedside, but now with these microbubbles, we're able to better diagnose these patients and better opacify so we're not having to order additional procedures or do a follow-up study because we were unable to see the first time. If you've seen it, again, this is the little microbubble generator, our Orbis. It fits any 10 millimeter syringe. So all you have to do is just hook it up to the saline syringe and inject it into their IV from there. So no stopcock is needed. It's a single-use device, and it's got a very finite amount of air and a little bit of polysorbate in it to help coat those bubbles and make them really bright and really diagnostic. Again, this is licensed by Health Canada, so it is available to all of you clinicians up in Canada. The indications for use, just to put it up there, is for contrast media via an intravenous catheter or needle, and to be used with a preloaded saline syringe during ultrasound procedures with agitated saline. Just a little bit about looking at how we've looked at these Orbis bubbles compared to our regular standard of care and why this is important. When we're talking about safety, I think one of the things what we think about is bubble size. So I know there's been times where I've been at the bedside explaining an injection to a nurse and they say, wait a second, you're going to inject bubbles into my patient's IV? And I go, no, 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 we do this all the time. But those standard of care agitations can really produce a huge variability of bubble size. So if you see this graph on the left, the standard of care range was from about 60 some to about 15 in bubble size in microns, and the Orbis bubbles were a consistent 28 microns for every single bubble. So that just means that when they opacify the right side, you won't be able to tell the difference in the bubbles. I tend to see in poor bubble studies, you can sometimes see the bigger and the littler bubbles. We also looked at peak echogenicity of these bubbles compared to standard of care, and saw that these Orbis bubbles are brighter. So, in those cases where it was a little trickier to see it over on the right-hand side, this really may be a solution to help visualize then come in on the right side even better. And then finally, the duration of echogenicity was longer lasting in these Orbis bubbles. And so, to rule out patients that have those late shunts, that have those PAVMs, is going to be really important that our bubbles last long enough to even see them. With standard of care, when I think about those couple cases I showed with only the few bubbles coming in, those wouldn't even last long enough for us to know if there was a pulmonary shunt as well. Again, I want to leave you with this diagram of how to perform a diagnostic Valsalva. Remember that the timing is really crucial in this. So you'll have the patient bear down. I usually like to do a practice run with them bearing down before I do the injection, just to make sure they have that in the kind of it right before I go ahead and use up my bubble study. But you'll have them bear down, maintaining that imaging window. And as they're bearing down, you should start to see that inner atrial septum shift into that left atrium, showing you that that pressure is increasing and that you are performing a diagnostic Valsalva. At about 5 to 6 beats is when you start injecting the saline, so that by the time it comes into the right atrium, you can have them release. And again, if it's positive, you'll see those bubbles on the left side. And then finally, just another image when we were talking about, looking at these images and optimizing them for a bubble study rather than maybe your left ventricular function or, looking at a valve. We can really, I like these images because we can do a more left atrial focused image to really help bring out the entirety of the left atrium and those pulmonary veins. So how to kind of maneuver from the top image to the bottom image, you may move you may actually move windows a little bit. Sometimes I find a little more lateral window can be helpful. Tilting the probe slightly anteriorly to open up that left atrium. This might be towards that 5-chamber view, but without the aortic valve coming in. And then rotating the probe a little bit just to elongate that left atrium. So again, in this top image, we see this is a very on axis for the left ventricle, and the bottom is on axis for the left atrium. I like to have the patients practice Valsalva before the injection. That helps me to assess movement and any image degradation. So if I need to move my image, I can. And you're saying to me too, if the apical images are poor, Maddie, what do I do? And thankfully, we can use a subcostal image to also do these bubble studies if needed. But what I'll suggest is, you usually get your or subcostal 4-chamber with the RV kind of more anteriorly. If you can adjust the probe to have it look like similar to an apical 4-chamber where you're having it slightly at an angle, that may be more diagnostic, just because if you're a little more vertical to that transmission and to the injection, that attenuation might come into the LA or the LV, leaving you with a little bit of an undiagnostic study. So those are just some tips to help with image quality and to make sure that your bubble studies are the best they can be. And with that, I will thank you for your attention, and I think we'll turn to some questions if there is any. So I'm going to go ahead and stop sharing for now. Or actually, I'll leave this up at the end, but we can take a moment for questions.
Here's Martin. I just want to remind you to use the Q&A tab to answer questions. All the questions regarding like prices or the commercial part of it, that will be taken offline as this is a clinician presentation. Maddie, you didn't. I may have a question for you because I get a question from a sonographer. Some sonographers scan from the left and some from the right. Can you give me a little tip of how we can do the setup? Are we putting the IVs in the right side and left side? If you can answer that, it will be very useful.
Oh yeah, of course. So typically, for any type of bubble study, you can do it from, scanning from either hand. I am more of a left-handed sonographer, so I tend to, scan left-handed, but if you're reaching over the patient, I prefer to have the IV in the right arm that's kind of lying on their hip when I'm doing these injections. Really, either way that I'm scanning, right or left-handed. I find that because the patient is on their left side and sometimes they're lying on that arm, that can be a little trickier to get to. And especially if you're using something like the Orbis microbubble generator and you're performing these yourself, you would be able to, just like you would with a contrast agent, be able to have your image, with your left hand and then inject it with your right hand as well. So the hope is that, that we wouldn't have to necessarily wait for a nurse and that you could perform this yourself right at the bedside. I hope that answered your question.
Yes, it did. We have a question on the question and answer tab. The
Please.
question is, how many times can the bubble study be repeated within the same scan?
That's a great question. I think my clinical advice is that most I think I will say the blanket answer of it is really up to your institution, how many times that, kind of a protocol, if you will, if there is any times won't go past. I think typically, I've seen up to 6, 9 injections on a patient just to, have this, I think that, anecdotally, um, yeah, I've seen it where we really were trying to have the patient, do a Valsalva, or the bubbles weren't, performed well enough. And so I had to do it more than once. Um, I had to do it
Maddie,
probably
if
more
if
than
I
three
can
times.
with the if I can interject here,
Yes,
in a
please.
Canadian product monograph, you can use up to 4 devices per patient per
Perfect.
hour. So uh,
Okay.
that being
Thank
said,
you.
the experience we have right now, sonographer tend to use just one device.
Perfect. I was going to say that you typically, in practice, I'm usually only doing one or two because the study itself is quality enough that I've thought that I got a good diagnosis.
We
But
have three
thank you,
more questions.
Martin.
We have 3 more questions, so we're going to speed it up just to finish in the
Perfect.
time. Another question, and how do you do the Valsalva? How do you do the Valsalva or increase intrathoracic pressure during a TEE when the patient is sedated?
That is really challenging. In my experience, I know that I haven't necessarily, I'm not the one performing TEs, but we do a belly push for those patients. So we're kind of forcefully pushing the belly in and then having it, release. And that has been used somewhat. I know other labs will only do moderate, like a little bit of sedation, kind of a twilight for the patients so that they're able to perform the Valsalva while they're under sedation.
Okay, we have another question. If we see the shunt by color or 2D, can we reliably measure it?
That's a great question. I would urge people to try to do a bubble study because that will be kind of the most diagnostic way of seeing this. But if you're already seeing it with color, especially the ones that are a little bit um, bigger with color. I think there are opportunities to measure it, but I think transthoracic limits us a little bit with those measurements. So on TE, yes, I think you can do some measurements with color. On transthoracic, I haven't personally had a case where I've done that, and I would want to trust a bubble study more.
Okay, now we have a series of questions, so get ready. So as you
Okay.
stated, there are different standards in literature when it comes to bubble studies. With this in mind, when would you start counting to determine if it is within 3 beats or not?
That's a great question. I typically use the after the RA is completely opacified. So usually that takes about 2 cycles, and then I'm starting to count. If you're just seeing that first puff of bubbles, I don't start counting there.
So we have a comment, great presentation. The Valsalva maneuver is very important as doing it can make a difference in confirming a PFO. I have seen patients that show a negative bubble study, but once I do it with Valsalva, it becomes positive. I also tried to get a modified tilted four-chamber view similar to four-chamber axis view. Some patients even have a clear subcostal view. You just need to press a bit. And another question, please clarify that the patient needs to do the Valsalva for 5 seconds before we can start injecting.
Yeah, it's just that they need to start. Because the Valsalva technique should take about 10 seconds, they should be bearing down for about 10 seconds to accumulate that pressure. That's why I suggested at about 5 or 6 to start injecting. If you're starting to count, they're bearing down, you're like 1, 2, 3, at 5 or 6 was when I would inject so that they've already had that pressure built up before you do the injection.
And the last question we have for now, would you do the bubble study in a different way if the patient has an ASD device and you are ruling out a residual shunt? And the second question is, what about in patient with dextrocardia?
Well, challenge, that would be a huge challenge if it was dextrocardia patient. I don't think I've ever done a bubble study on a dextrocardia patient. If they had an ASD closure device, PFO closure device, ASD, I would perform this exactly the same way. And same with the count, are relatively, what we use for counting the 3 beats and everything, I would still look at that. And assessing, yes, if there is any residual shunting, you're just looking for, again, little bubbles over on the left side, but it shouldn't be any different from your regular bubble study. If you had a patient that was dextrocardic, I don't think that I'm trying to think of just the way that you would scan them. Usually I would tilt them on their right side to possibly get that better apical image, but those patients, as whoever asked that question probably knows that those patients can be very challenging to scan. I'd say if you can't find a great apical image on them, that maybe their subcostal window would be good enough for that.
No. Another question has been added. Is bacteriostatic bubble is superior to agitated saline?
Um, I think it has in studies done with bacteriostatic saline, kind of these additions, we know that it is better than the standard of care, with just a regular saline syringe. In the studies that we've been doing with Orbis, we've also showed that the quality is as good with these additives as the Orbis device is. And so, yes, if you're thinking of just your standard of care with just your regular saline, yes, bacteriostatic saline or a blood addition or dextrose addition may help enhance the bubbles by kind of giving them an extra coating.
So we are closing on the hours. Maddie, do you have anything to add? Uh,
I do not. Just thank you so much for your time and attention this evening. I hope everybody has a great holiday season.
In conclusion, don't forget your survey for your certificate. Please do it on a timely fashion because it's a lot of work and I want to get it done by the end of the year first. And secondly, if you're interested to try our best, please ask your manager to contact me. We have like special offers for this, and we also have it's a very simple device and it can really help with your workflow in this holiday season. On this, thank you so much and have a great evening.
Thanks all.